Hello, and thank you all for joining us on our latest installment of the series VisualDx Academy Master Educational Program. My name is Dr. Stephen Chen, and I'm the Clinical Director of Education for VisualDx. We're thrilled to bring to you an important conversation on Kodachromes, hair disorders in patients of color. I want to begin by thanking the series sponsor, Janssen Pharmaceuticals, for supporting this effort. Before I introduce our presenter, I'd like to mention a few things. This presentation is being recorded and will be shared to all registrants. We've allotted some time at the end today for questions. Now, we're going to run this session a little bit differently than prior VisualDx Academy sessions, and so today I'd like for you all to get a little interactive right off the bat. Within your screen, at the very top of the window, you should see that there's an educational supplement for you to download. Feel free to do that at your leisure. Additionally, you should also see a Q&A tab, and that's where I would love for you to experiment right now. We're going to use the Q&A tab a lot more today, as our speaker is going to be asking for some interaction so that all of you can propose your favorite diagnosis for some of these Kodachromes. So if you don't mind, use the Q&A tab now, perhaps send a message to the rest of the group here, send a message to our speaker, but try that out now so that you're ready to go when we have our first Kodachrome up for diagnosis. Let me now introduce our presenter. Dr. Chesahna Kindred is a board-certified dermatologist born in Oakland and raised in South Central Los Angeles. She is the president of Kindred Hair and Skin Center in Columbia, Maryland, and medical director of VisualDx, where she serves as a liaison to the physician community and an advocate for the delivery of equitable, unbiased care for people of color. Additionally, Dr. Kindred is chair of the Dermatology Section at the National Medical Association, associate professor at Howard University, founder and president of Onyx Medical Society, leader of the Health Committee of the African American Roundtable of Howard County, and deacon at Celebration Church. As a speaker and published author, Dr. Kindred's work and research culminate to improve race equity. She lives in Howard County with her husband, Jamal, and two children, Michaela and Kingston. Thank you for taking the time to discuss hair disorders in patients of color. Dr. Kindred, let's begin.
Excellent. Thank you, Chen, and thank you, VisualDx, for inviting me to talk about something that I absolutely love. And let's get started right away with our quiz. And it's not going to be a lecture, I'm just talking. Tell me what you think this diagnosis may be. Both of these patients have the same diagnosis. And if you guys could enter what you think the most likely diagnosis is, and I'll give you a couple of more seconds to complete what you think might be the case. You get no history, you don't get to touch it, feel it at all, just put in what you think might be the answer. All right, so let's move on. This patient also has the same diagnosis, and the answer is CCCA, central centrifugal cicatricial alopecia. And we see just zones devoid of follicular openings or follicular ostia. We also see that she has some hairs where the growth is just stunted. This is probably the less involved area. You see a nice full density, thick curls, and very obviously sparse. Of course, in the history, you would ask further questions. These are also cases of CCCA. And this patient, I'm pretty confident, is probably quite inflamed. I know you can't quite see the erythema. It's usually masked by the melanin. And here's also a patient with CCCA, and these are quite typical cases. What I'd like for you to note is, while this is indeed in the crown, you see how, if this is her forehead, how forward it comes. So it's not always just in the front. So that's something to be mindful of. So how do you diagnose it? I am of the old school. I biopsy definitely every Black patient, but every patient that looks like anything other than androgenetic alopecia. But a lot of patients have more than one diagnosis, so we do a lot of biopsies in my practice. And the biopsy will give you these typical characteristic findings. premature desquamation of the inner root sheath. Now, you'll hear that a lot, but what does it mean? But basically, there's supposed to be a protective gasket around the follicle that keeps the outside and keeps the follicle protected. We kind of lose that protective gasket. And what that looks like histologically is premature desquamation of the inner root sheath, which also can be seen in other diagnoses. You get some atrophy and chronic parafollicular inflammation. My pathologists, who I adore, Dr. Lynn Sperling and Dr. Green, they tell me if the inflammation is mild, moderate, and severe. And that helps you to understand how much hair loss is coming down the pipeline. So if your pathologist doesn't give you a sense of that, you may want to ask about that. Dermoscopy is increasingly popular. I don't rely on dermoscopy, but you have a great lecture coming up after me on dermoscopy, and you can use it to find the biopsy site. But if you have an exceptionally keen dermatopathologist, I would lean on the dermatopathologist. Also look for symptoms of inflammation, and they're usually present. What you have to watch out for is sometimes patients do not know they have symptoms of inflammation. So you want to ask, they have itching, burning, stinging, pain, tenderness, soreness, sensitivity, whatever terms that patient uses. I promise you, whatever symptom of inflammation they have, they're probably blaming it on something that's completely unrelated. Rather, like, oh, I just need to grease my scalp, or it's time for me to wash my hair. Well, I turned that electric heater on the other day. The electric heater one I just heard not that long ago as a reason. So you have to educate your patient your patient to recognize those symptoms of CCCA, because after the biopsy, you rely on the waxing and waning of the symptoms to tell you if the CCCA is getting worse or if it's controlled. Next, your signs, that's symptoms, the signs you'll look for. Hopefully, you're going to get patients very early, not as severe as the photos I just showed you. What you want to do is have the patient part their hair down the center, and you're looking for the part to widen. In areas where it's widening, then that's probably a hot spot for CCCA. But then keep in mind, it can be eccentric, it could be in the front, it could be on the side as well. But the classic early sign is somewhere around the center where there's some symptoms of inflammation and tenderness. That's where you're going to have a great biopsy site for early diagnosis. Late diagnosis, just way too much scarring. So that patient that I showed you here with treatment on the right here, this is where she ended up with medical management and without a bunch of fancy stuff. So medical management really can make a huge difference, but there's pitfalls. You have patients with no symptoms, which is a bit unfair, meaning that inflammation is flooding their scalp, destroying their follicles, and the patient has no clue until after they've lost a ton of hair. And these are usually the patients you see really at late stages. Then I have a ton of patients that have CCCA and androgenetic alopecia, and quite often CCCA and traction alopecia. And then there's also clinical bias. For some reason, some dermatologists feel that if it's a patient who looks like this with wavy instead of tightly curled hair, then it's automatic androgenetic and not CCCA, and that couldn't be further from the truth. So be careful. And I actually have a Latina patient who identifies as a white Latina, and she has biopsy-proven CCCA, and it turns out her great-grandmother was of African descent. Inflammation is the most important. So if you do nothing else, address the inflammation. This is you stopping it from worsening. I use potent topical corticosteroids, particularly hyaluronide solution or clobetasol ointment. I don't use solutions that contain alcohol, especially for curly hair. It dries it out and causes trichorexis nodosa. Intraluminal triamcinolone, I do it monthly for a full 6 months. I know some people do 3, but I found doing it for 6 months to be more successful. And then we back off based on how active the CCCA is. And then everybody gets an oral in my practice: doxycycline, hydroxychloroquine, and even baricitinib, which I am impressed with. And then there's a lot of newer things that we do. Well, some things are old, right? Platelet-rich fiber matrix, it's been around for quite some time. Very, very effective. It's tried and true. We use synthetic growth factors. And then sometimes we just need to camouflage, and we use scalp micropigmentation, particularly if it's really scarred, and some of these other modalities are not in the patient's budget. For those of us that do hair transplantation, it's only after the inflammation has been well controlled. So that was CCCA. Next, we have this. So you can take a look at these two patients and tell me and put in the Q&A what your suspected diagnosis is. As you guys are typing, VisualDx has really, really excellent handouts on CCCA, and that'll help supplement what we're talking about. Honestly, excellent handouts and synopsis on all of these diagnoses. And a couple of more seconds to guess your diagnosis here. Okay, so this is our androgenetic bread and butter alopecia and derm alopecia. What we see is you see that the follicular, they're not scarred, right? Then there's have that smooth appearance that's pretty classic of CCCA. There's always exceptions to the rules, but this is one of the helpful findings, is where you can still see follicles, even if there's no hair coming out. There's also pretty normal size shafts, nice and normal size, and then also very just wispy, thin shaft. That's that miniaturization. A miniaturized follicle makes a miniaturized hair. Here are more cases. What I find to be quite consistent with androgenetic alopecia are the triangles, right? For guys, it drives them crazy, particularly for Black men, because for most Blacks, our hair doesn't grow down to cover this up. The hair grows out. So if this occurs, it's very difficult for them to hide it. And their barbers get pretty creative, but this can be quite bothersome. This is a great example that every Black woman with thin edges does not have traction alopecia, and this is androgenetic alopecia. Remember, I biopsy every patient, so I have a ton of patients that look like that. Those triangles are really great clues that it may be androgenetic alopecia. Typically asymptomatic. Every so often, and it's not common, but patients can have just this kind of inflammatory sensation. There's a diagnosis coming up that I really think is more accurate than androgenetic alopecia. And AGA does have a typical pattern, whether you consider Norwood pattern or Ludwig. Most patients will fall into one of those categories. Again, I'm old school, particularly if they're Blacks, they're getting a biopsy, because CCCA is by far the number one diagnosis. And if I'm catching it early, CCCA can look like AGA. Whereas when I biopsy white patients, Latinx patients, Middle Eastern patients, so on and so forth, and if I think it's AGA, it usually is AGA. Rarely has there been an exception or a surprise. Here's some pitfalls, and that is patients who actually have fibrosing alopecia in a pattern distribution. And what we see on the side is a patient with that case. So she had a biopsy that said FFA, quite classic for FFA. But I was impressed because when I was treating her, she responded like a patient with AGA. And it took me embarrassingly 3 years to realize, oh my goodness, she has FAPD. And it's just a diagnosis for some reason, me as a hair expert, I forgot about. So keep that in mind. So it will respond better than FFA, be a bit more resistant than AGA. And sometimes the pathology will be spot on, but sometimes it's not. And then again, another pitfall is patients with AGA who also have CCCA or another diagnosis. How to treat. So my favorite is actually minoxidil. If the patient prefers topical minoxidil, we compound it. Some people do 6%, 10%, 12%. I tend to do 12. Dutasteride and finasteride are also gaining popularity, but my favorite is actually oral minoxidil. We've been using it for a few years and we rarely see side effects. We prescribe antibiotics, more concerning than the low dose oral minoxidil. And then there are natural supplements that are medical grade, and they work. And they work well for AGA. And some patients do very well if we combine an anti-seborrheic shampoo with one of these natural supplements. And we check on them every 6 months to make sure that they continue to do well. AGA, while it can be devastating and it can get severe, it's not as refractory as CCCA. And some of the similar things we do for CCCA, we do for AGA, such as PRFM, PRP, synthetic growth factors, hair transplantation. I never do hair transplantation without having at least 2 out of the top three things here on board. Hair transplantation isn't a cure, right? It's a bridge or a Band-Aid, and we also do scalp micropigmentation if the patient prefers. All right, here's our next question. What's the diagnosis for these 2 patients? They have the same diagnosis. And I'll give you a couple of seconds to throw your answers into the hat. All right, so this is FFA, and the eyebrows are telltale for FFA. There are thin eyebrows in CCCA and in androgenetic alopecia. So it's not like a sine qua non, but it tends to look more scarring, if you will, more patchy. It's not just thinning. It's as if, you know, it looks like a scarring alopecia does on the scalp sometimes. Sometimes there's erythema. And if you can appreciate it, in this patient, you see some hypopigmented perifollicular kind of papules around this patient, which is a hint. And you could kind of see this papule glistening off the reflection in this photo. And I don't see that with other diagnoses, not even CCCA. And of course, my son is phonobombing. Say hi and then go, Kingston. Yes, go. Since 2020, there not have been a meeting that he hasn't photobombed. So this is FFA. And very classically, you have this hyperpigmentation here. Usually it's like, well, we'll go over it, but LPP. And then look here, these erythematous papules. Someone coined the term alone hair, which you'll just see standing out by itself. And this helps you to really give you the diagnosis of FFA. And it's increasing, really increasing in frequency. And yes, I'm a nerd. I biopsy these patients too. So why? Most of us can look at this, say it's FFA, and you're gonna be right. But for my practice, 50% of my patients are hair loss patients. So even if I'm correct 90% of the time, for me, 10% is a ton of patients. So I still even diagnose FFA, and I've had cases of FAPD, traction alopecia when I'd expected, et cetera. But clinically, there is a typical pattern. You won't get burnt too much by suspecting that it's FFA and moving forward with treatment. We talked about the eyebrows. If it looks scarring, it's going to be FFA, but you can have a non-scarring loss. And then lichen planus pigmentosa is what I was referring to, that discoloration. So if you have someone that looks like traction and they have melasma, really think about FFA. And then facial papules. There's usually skin colored across the forehead. And then dermoscopy can also help you to diagnose FFA. Pitfalls. It's if you guys feel like you're seeing more FFA than you have, say before a couple of years ago, you're correct. There is an increase in FFA. And back when I was in residency 12 years ago or so, I think even in a textbook, it was supposed to be white women, middle age, wealthy, something like that. Throw that out the door. I have 20-year-olds with FFA. I have every race with FFA. I'm diagnosing a new one at least once or twice a month, which is just so unheard of. It used to be once or twice a year. So really have a radar for FFA. And that's what I mean by this outdated demographic. Just throw it out the door. And FAPD, this patient could mimic FFA. What's tricky is sometimes the eyebrows will start to be involved before the scalp. And I got burnt. I immediately thought it was alopecia areata. And then next we know, like I think a year later, we started seeing her hairline recede. I usually see it the reverse. And of course, many patients have more than one diagnosis. So topical corticosteroids or TCIs. So I'm a huge fan of topical corticosteroids for FFA if it is active, right? If it's on fire, it's red, and it's just burning through the patient's scalp. You do risk some atrophy. So just keep that in mind. But as you have it under control, please feel free, switch over to a TCI, and it should keep it maintained, and you can live happily ever after with just the TCI. But I've seen patients where I've had to whip out a cortisone to shut it down. The atrophy will reverse. It will reverse. I do IOK as well, which is starting to fall out of favor. But if the patient is on fire, I have to put the fire out, and then we adjust from there. Dutasteride. I was late to the game for dutasteride. I had a patients on it, started with a few patients, and I saw nothing month after month after month. And I'm used to seeing better, fast results with oral minoxidil. And then it's like a light switch turned on right around month 8. And I shouldn't have been surprised because FFA is one of the toughest diagnoses that we treat. So I am a fan of dutasteride now, 0.5 milligram. Sometimes you can't rely solely on it, but combination treatment is the name of the game anyway, right? And I still use hydroxychloroquine and doxycycline for anti-inflammatory. In some patients, FFA simmers, and some of them is just, a blaze rolling through their scalp. And that's how I adjust whether or not doxycycline, hydroxychloroquine, dutasteride, et cetera. I think we're all figuring out the best algorithm for these patients. So I really recommend have all of these in your toolbox and start to get a feel of what's better for which patient. Prednisone. I've had to, when I've thrown everything at the patient, give the patient prednisone to shut it down. And it's not doses any different than what we use for other dermatitis. For the facial papules, you can try, topical retinoid, but really isotretinoin, a low dose, QOD, it works great. It really does if you're willing to jump through some of the hoops required for prescribing isotretinoin. Now for the next case, both of these patients have the same diagnosis. I'm going to give you a few seconds to put in your guess. All right, so this I'm sure you guys got was traction alopecia, but I want to point out honeycombing. I wish I would have written this up. I've known about this for years. I never thought to write about it. So this is one of my patients. She took her locks out. And you almost have like a honeycomb appearance. And this is a great photo in VisualDx that just can kind of help you to understand how you can go from here to here. It's not bizarre. It's just they had locks. And so they had these chronic parts. And as you can see how tightly her hair is pulled. Please get familiar with locks because it's notorious for traction alopecia. But when they tighten the locks, the last step in tightening is they do something called a palm roll. That is, the locks are tightened, right, twisted. And then to really get a tight twist, they take the locks between the hands and do like this. And it really creates a tight pull. But you might want to tell your patients, tell your loctician to be a little lighter, of the hand and maybe not do the palm roll. And the loctician will understand to the patient what you're asking. By the way, we don't call them dreadlocks. Dreadlocks has like a racist history. And so just call them locks. And that's what your patients will appreciate it. Traction alopecia fringe sign. This is also something we knew about in residency at Howard. We didn't think to write this up and we still kick ourselves sometimes. But the fringe sign, you have the original hairline, a zone of hair loss, and then the new hairline. This quite often is going to be traction alopecia, more cases than not. It's not a sine qua non because I have plenty of patients with other cases, such as our patient with FAPD, who kind of sort of had a fringe sign. This is traction alopecia. So how to diagnose? Not every Black woman with thin edges has traction alopecia. Not every traction alopecia patient is a Black woman. Ballerinas, volleyball players, military, traction is notorious. With a wig, you get traction alopecia in the back of your scalp. So again, I'm the old school nerd, I still biopsy, but you can diagnose it clinically by the pattern. Usually the eyebrows are full, and the history will tell you. Braids, such as what I have with extensions, if they're too tight, ponytails, so on and so forth, can help. And then dermoscopy can help as well. Again, it's a great lecture coming up on dermoscopy. Pitfalls is ophiasis, alopecia areata ophiasis type. That can indeed mimic traction, particularly if you don't have the exclamation point hairs, if you don't have round circumscribed patches of alopecia. Frontal fibrosing alopecia, FFA, most certainly can mimic traction alopecia. I have traction patients that look like FFA and vice versa. And I have androgenetic alopecia patients that can look like traction patients and vice versa. So don't be too quick to just chop it up to traction, even if the patient has locks. The other problem is when a patient has hair loss, they may employ hairstyles to cover up the hair loss, and the hairstyle causes traction alopecia. So you sometimes can't just automatically tell the patient, stop doing that, right? Really try to understand what led to it. And then with sensitivity, try to make sure the patient uses healthy hair care practices. And again, what's bitten me quite a few times is I think they have traction, turned out they had traction and AGA. And remember, the AGA and CCCA really damages those follicles. So you get pretty weak hairs that aren't the same caliber as normal hairs, and they're more prone to traction, even if the patient is careful about their hair care practices. And then atypical patterns of traction alopecia. We discussed honeycombing not too long ago, and then sometimes you don't get the fringe sign. Next, how to treat traction alopecia. The most important is avoiding hairstyles that create tension or friction. And then this is where the stylist is really key. So I'm the first dermatologist to have a full service hair salon in my practice for our hair loss patients. And I can't emphasize how key hairstylists are. They keep your patients compliant. They train the patients, teach the patients to do healthy hair care practices, so on and so forth. But you have to connect with your traction alopecia stylist, whether the stylist is the patient or is someone else, to get it to avoid worsening the traction alopecia. If there's inflammation, use topical corticosteroids or injections. If there's no inflammation, there's no need for an anti-inflammatory. And then next, some of the similar things that we saw before with other hair cases. Oh, I will point out, nothing works as well for traction alopecia as hair transplantation, and nothing responds to hair transplantation as traction alopecia. It's like the perfect match, by the way, but still see if you can try to save some hairs and follicles with other modalities, and then go to hair transplantation. All right, here's our next one. Couple of seconds. This one, right, is pretty straightforward. What's your diagnosis? A couple of seconds. So alopecia areata, really classic, well circumscribed patches of alopecia. And the cases here as well. So how to diagnose? I will admit, this is the one, if it's classic, then I may not biopsy. I've never seen a classic alopecia areata biopsied it, and then it was something else. Like this, it just hasn't happened. Every so often I have a patient with alopecia universalis, just complete hair loss. And when we get the hair to grow back in, it doesn't grow back in the expected pattern, in which case I might biopsy it to see if it's multifactorial. But I haven't been burnt by a classic case of alopecia areata. I've been burnt by other diagnoses. But if something's not acting right, then I'll do a biopsy, as I mentioned. And the pitfall is patchy alopecia. This is a great example. This gentleman, I'm telling you, I would have lost my house. I thought he had androgenetic alopecia, right? The Ludwig type, where it's sparing the frontal hairline and his hair is curly. And so I thought that's why this was the distribution. And no, sir. We did a biopsy and it came back as alopecia areata. So if I didn't believe in biopsies before, then I certainly did after this case. And he responded just like an alopecia areata patient. So be careful for this kind of diffuse pattern. And he did not have a positive pool test. There were no other hints. Also, a pitfall is alopecia longer than 10 years can be really refractory and tough. And another case is for him, what if he did have male pattern hair loss and I biopsied the male pattern hair loss spot and not an alopecia areata spot? I don't know how I would have been able to tell the difference, but if you do biopsy it, sometimes you can get the wrong spot. And I love what Dr. Brett King says about alopecia areata, which is the only predictable thing about alopecia areata is how unpredictable it is. And that is, you don't know if it's going to go from patchy to just universalis or just stay patchy. So keep that in mind with treating. So how do we treat? Topical, intralesional, and intramuscular corticosteroids. If it's pretty diffuse, then I would do IMK. But now, if it's pretty diffuse, I tend to go straight to baricitinib, which is the first and so far only FDA-approved medication for alopecia areata. There are some other things that work. Linanapros works, but there is a new device that I'm a little bit in love with, and it's the 308 nanometer excimer lamp. Well, the lasers work, but the lamp is just a little handheld device, and you just zap it for a few seconds over the alopecia areata, and it's quite impressive. And then, as an adjunctive, we can do antihistamines and even some statins. But as far as orals now, I've totally switched over to baricitinib. So we covered CCCA, AGA, a little bit of fibrosing alopecia and pattern distribution, alopecia areata, and others. And so once again, I'd like to thank VisualDx for inviting me to give a lecture on a topic that I absolutely love. Dr. Chen?
Dr. Kindred, thank you so much for that wonderful review and introduction to a lot of these topics that I think many of us in dermatology, unless we have the right patient population and are really looking for it, are not as well versed in. So thank you. I really appreciate it. And I know I learned a ton too. We have plenty of time for questions. So at this point for our audience, please use that Q&A. We're going to convert the Q&A from a place for you to put answers in now to a place for you to put questions in. So any questions that you have for Dr. Kindred, now's the time to put them in. And then I'm happy to pass those along to Dr. Kindred, who will obviously answer them in real time. While we're waiting for some of those questions to roll in, I had some of my own, if that's okay. Yeah, so just to start, I think when we're thinking, I love oral minoxidil for the treatment of androgenetic alopecia. And, I've talked to a lot of people who treat a variety of hair loss patients, and I've heard a wide range of doses. I'm just curious if there's a max dose that you ever go to, or if there's a typical starting dose. I know it changes based on the patient, but is there like a dose that you will never go past?
So my max is 5 milligrams. When I started prescribing it, I didn't have a bunch of colleagues prescribing it. I started like 18 or 19. So I didn't have like a go-to. So I was scared. So I started at 0.625 or something, which is a quarter tab. And I had everyone check their blood pressure, and we checked it, and nothing was happening. Some people actually responded, believe it or not, over a quarter of a tab. So anyone else who was scared like I was, you're fine. Use a quarter tab. But then we went up to a half tab, things were fine, and then a full tab. Okay, so now that I've been using it for some years, my little old ladies, those are only ones where I've really seen side effects, and it gets swelling of their ankles. Okay, half a tab. Young and healthy, everyone starts on a full tab. And then if we're not seeing a good enough response, we go up to 2 tablets or 5 milligrams. If they're on a high blood pressure medication, they have to get clearance by their main doctor or their cardiologist. And almost always when they see the doses that I'm prescribing, They don't even care. They say, go ahead and start it. But if I go to 5 milligrams, I have them run it by their primary care doctor again.
Wonderful, great. And then one other question, and please, for the audience, please keep throwing those questions into the Q&A, but I'm gonna take advantage of being the moderator and get to ask my question first, which is, when you see, I love your tip about biopsying and how, especially for someone who has such a high concentration of hair patients, that, a diagnosis 10% of the time that's off is so important. Just curious, for FFA in particular, where do you like to do the biopsy? Do you go more towards where like the lonely hair is, or do you go more towards where the new hairline has established its spot? Is there any tip, or maybe going for any tips you have for location of biopsy?
Yeah, that's a good one. So if this was, let's see, let's take a minute to, oh, I'm so sorry. I thought that was the number. Let's go over that. Now I wish I would have emphasized that a little bit more. So for a patient like this, you see like this patchy area here or here. So I would go right around here, because it's guaranteed these hairs are the next set to go. Okay. Whereas someone, let's say the patient, this is a great example. For this patient, she has an on button and an off button, right? There's almost no in between. So it's very easy to go too far this way or too far this way. And I've unfortunately had patients where this was normal and this was scarred. So you really have to really look for an area that's the next, that you think is just the next area to go, which for her is probably right around here, right? You can't go, you go out here, it's just going to say scarring. So some of them have a sharp demarcation, whereas this person is very obvious. You can probably do anything here almost, and it'll show FFA because it looks all active.
Great, perfect, thank you.
Mm-hmm.
All right, I'm gonna start throwing in some audience questions for you, if that's okay. The first question: do you have any trouble getting any medications for your patients? And specifically, do you have any tips for getting baricitinib approved for your alopecia areata patients?
I knew that was a Barry question. So 2 weeks ago, finally had an insurance company that asked me to do a SALT score. And I am taking the time to do a peer-to-peer to waste their time, but they're trying to waste my time about the SALT score. So hopefully I will shut it down for everybody. Everyone enrolls into the the Lilly Savings Program. And then we write a letter about the quality of the impact that alopecia has on the quality of life. So some patients can get it covered even if they have CCCA. This is so off-label, but it is, right? Because no one's made anything for CCCA. So everything I said for CCCA is off-label. But my alopecia areata patients can get it, thank goodness. One successful tip is we'll start them on the sample. And then when we document that the patient is doing better, the inflammation is better, and we send that in the appeal letter. I hope that's helpful.
Yeah, and I guess just to throw a wrench in that, what if your practice doesn't have samples? Let's say, so for example, I'm in an academic practice and we're not allowed to have samples. Do you have any tips for what to write in the appeal or your documentation in order to have a higher chance of success when you're filing for your prior auth?
Right. So what we say is ask the patient how it's affecting them, right? Mm-hmm. Are they spending money buying wigs or etc.? If they have a history of depression, we ask if they're not indicated for hydroxychloroquine. They clearly can't be on doxycycline high doses for too long, so on and so forth. Throw everything in there, including the kitchen sink. And then sometimes we use other JAK inhibitors, tofacitinib. Before Barry was approved, we used a lot of tofa, and it was effective.
Great. And then kind of a related question, how often do you like to draw labs for baricitinib?
So I get baseline labs, and then I check a CBC about a month later. At 3-month mark, I check lipids. And the baseline labs are CBC, TB, AST, ALT, BUN, creatinine, And I do check a creatinine kinase. Even though if it happens, it might be transient, I still check it. And then TB once a year, and I just make sure they're following up with their primary care doctor for just like their regular annual labs, which includes everything I would have checked anyway.
And you said lipids at 3 months. Do you also check baseline lipids too, or just wait for 3 months to do
I
that?
check it. The FDA did that. It doesn't make sense. Check your lipids at baseline.
Yeah, okay, sounds good.
Mm-hmm.
Next question. How important is it to have a dermatopathologist experienced in reading hair slides? Do you recommend sending it out every time? And if so, any particular recommendations?
You know, it makes a huge, huge difference. So I totally understand for derms who don't have a dermatopathologist specializing in hair loss, where you forego the biopsy. I do get it, but gosh, it makes a difference. So the same way we as derms are all hair experts, right? We're all hair experts, but some of us jumped in on the deep end, right? Same thing is for pathologists. You know, all the dermatopathologists can read alopecia, but some of them are just phenomenally exceptional at it. If you have one of those at your disposal, or you have one who's willing to make that their niche, go for it. I've When my dermatopathologist was sick and others had to read it, I was like, oh wow, ooh, it's tough in these streets. So try to find someone that is. Otherwise, you know, use your clinical judgment or whichever's best.
Great. And then, do you ever recommend making changes in a patient's type of hairstyle? If
Mm-hmm.
so, what if the patient feels strongly about continuing to wear hairstyles that you feel may be damaging?
So I have the advantage. I have a stylist in my office, right? So I have CCCA, and you see I have braids. And for years, I've told patients you can't wear braids. It took us 6 years to find a braider that can adjust based on hair loss. So you have to find a stylist in your community, right, that knows how to adjust based on your patient's hair loss. Because there's two things that they need. They need a hairstyle that they like, that's socially acceptable, and one that's not detrimental based on their hairstyle. And some stylists only know how to do one or the other. So we have to recognize that while we can say what you can't do, the stylist can tell them what they can do. So if you're not familiar with the different hairstyles, techniques, etc., and I don't blame you, it's not our lane, right? You have to partner with the stylist that does, because you have to provide the patient with the solution. You don't tell the patient you have inflammation, figure it out, right? We tell them you have inflammation. Here's what you do to get rid of the inflammation. Same thing. You have a hairstyle is detrimental. Figure out a way, a solution of what they can do. So for our patients who get braids every summer, that was a huge problem for us. So we had to find a braider. And then obviously, again, I have a stylist in my office, so I'm a bit spoiled.
Amazing. Next question. I am a primary care provider in an internal medicine practice. Should I attempt to treat straightforward cases of alopecia, or do you recommend a referral to dermatology for confirmation of diagnosis and treatment in all cases?
So while I applaud your valiant effort, all the derms are like, there is no straightforward case of alopecia. Okay, so well, you're very, very, very likely to get burnt. So are you biopsying? You know, do you know how to recognize a good dermatopathologist? Are you able to read the report and really get a sense of how much inflammation, how bad it's going to be? Are you comfortable with JAK inhibitors for alopecia areata? Maybe by straightforward, because straightforward for Blacks is CCCA, right? You can take all forms of hair loss, add them up. There's more Blacks with CCCA. That's straightforward for Blacks. So I don't know if you mean straightforward as androgenetic alopecia, right, which is the most popular one that's known, the most common one worldwide. And then by taking it on, I don't know, are you talking about topical minoxidil? You probably are more comfortable prescribing oral minoxidil, you know, than we are. I would be careful. Like if you have a really good understanding of the basic science and pathophysiology of hair loss, maybe you have a go-to derm, or if you have a derm near you that can tell you what to do until they can get in.
It looks like we may have lost Dr. Kindred. I don't know if that's, wait, there you are.
I just gave the best answer. Y'all didn't hear that?
I don't know if that was me or if that was Dr. Kindred. So maybe I froze. I'm so sorry. Do you mind repeating it just in case? I heard all the way up until I don't know if you have a particular dermatologist that you partner with that you trust. So I heard about, I think 90% of it.
90% of it. Yeah.
Yeah.
Yeah. See if, whoever dermatologist is working with, find out from them what they recommend you start with until the patient gets to them.
Great, that's perfect. I've been told that it was not a me issue, so thank you for repeating your answer so that we could all hear the wonderful answer. That's great. Our next question, do you have any difficulty getting patients on board with oral JAK inhibitors, and how do you counsel on possible side effects?
Oh, wonderful. Because that's something I struggled when I started prescribing it back in 2017. And it's what I appreciate about the baricitinib BRAVE AA1 and 2 studies. So with the studies for TOFA and other JAKs, it was mostly like RA patients who were on methotrexate and prednisone, et cetera. And it was hard to tell which side effects was from the JAK and which one was from, just the disease or comorbidity. But with the BRAVE AA1 and 2 studies, that was what, I tell my patients, that was a clean study. The patients were generally healthy. They were on a monotherapy, meaning not a whole lot of other medications. And so we were able to really see what those side effects were. So now they know when they Google, they know if it wasn't from the alopecia areata study, they know it was for the rheumatoid arthritis patients. Then I say out of about 1,200 patients, one patient had a blood clot, but when she went to the ER, it turned out that she had a clotting disease, and none of the other 1,200 patients had it, right? You just go for the worst diagnosis. One patient had a heart attack out of 1,200, but it turned out he had a lot of risk factors for it. Nobody else did. And what you will get, possibly, is acne, right? If you have high cholesterol, and it's not controlled, there might be a bump, but we're going to check you now. We'll check you in a few months. But we didn't see cancers in that study. We didn't see deaths. We didn't see strokes. We didn't see anything that's alarming for me. And so that's how I tell patients.
Wonderful. All right, next question. Do you advise against microneedling for hair regrowth in cases of scarring alopecia like CCCA or LPP? I believe JAK inhibitors are only FDA approved for alopecia areata, but do you know if they're being studied for other conditions, for the scarring alopecias?
I hope they are, because I can tell you in my practice they work. I just don't have time to do that study. I guess I'm answering the second question first. I had a CCA patient. I still remember we started her on a JAK just this past May 24th. She came back a month later, and all her symptoms were gone, and she had been on everything I listed as for inflammation. She was on doxy low dose, brought her up to high dose. We had switched her over to hydroxychloroquine, and usually hydroxychloroquine works in my hands, but she was still inflamed, scalp on fire, tender, and shedding profusely. And she's only 32, so this is really devastating. She came back a month after being on a JAK, and her symptoms were gone. And then 3 months later, the shedding has completely stopped and we have some new growth. And I have plenty of patients where their symptoms are going away. Hopefully I believe someone is doing it for either FFA or LPP. And I don't think it's been published yet. Then the first question, what was the first question? The first half of that question is totally different.
Do you advise against microneedling for the scarring alopecia?
Actually, no, go for it. I wish I would have known about microneedling for scarring alopecia earlier. I just thought it was going to destroy the follicles. For me, it was just completely counterintuitive. It was Marianne Senna who presented at an NMA conference, and it just turned me to a believer. So I dabbled with about 10 patients, and all but 2 improved. And so we don't just microneedle though. We always combine with PRP or synthetic growth factors or exosomes or something like that.
Great. And then one last reminder for our audience, if you have any questions, now is the time to submit them so that Dr. Kindred, we have a hair expert online, so this is the time to submit them. So one last call for questions. And then one more question right now for you, Dr. Kindred. You mentioned natural supplements for AGA. Any particular ones that you recommend?
Yes. I have conflict of interest all over this talk. So I don't know if that makes me biased or unbiased because I'm sponsored by all of them. So the one I found, I sell two. I sell Nutrafol and I sell VisualDx Pro. I have too many hair loss patients. I have to sell both, but I find Nutrafol to be tremendously more effective. Conflict of interest, I'm on the advisory board and speaker and stuff like that. I think the reason might be because while it has the active ingredient, it also serves their multivitamin as their vitamin D, controls cholesterol, cortisol levels. So I think since it's more comprehensive, that might be a piece of it. Like low vitamin D makes the hair more brittle and it breaks off, and they're covered for that. But just to be balanced, VisualDx Pro, I think, is second best. And then two more that works are Inner Glow, which is designed by a dermatologist, and Lambda Pill. Those are the four. Anything outside of those four at this time, we haven't seen much improvement. And there's a lot beyond those four, but we don't see much with it.
Great, thank you so much. And thank you for noting your conflicts of interest before answering the question. One more question for you. Do you ever use methotrexate to treat alopecia areata? And if so, what are your thoughts? Is it effective or not? I have a patient that I've acquired who is on this treatment currently, but she's gotten worse. She's also on Humira for Crohn's, doesn't have insurance, and so not sure if there's a patient assistance program.
Okay. And what was the patient's diagnosis? Did they say it? Did I miss it?
It looks like alopecia areata.
Areata. So I haven't used methotrexate for alopecia areata. So I would, before Berry was approved, we were using oral tofa and then topical tofa. PRP is so-so. What else can you do? And then we would use Allegra and some of the statins. It's tough without approval.
Great. Well, Dr. Kindred, that rounds out all the questions that we received, including all of my own questions that I've gotten answered tonight. So thank you very much. If it's okay, we can move on to our next slide. And for our audience, our Master Educational Program continues on November 8th. We have a dermoscopy masterclass with Dr. Trilok Tejasvi. Key learning objectives for this upcoming webinar are to define the key dermoscopic morphologic features of melanoma, understand dermoscopic utility for inflammatory diseases, and to compare dermoscopic morphologic features between malignant and benign solitary lesions. And if you can see here that we actually have 2 webinars remaining this year. Notably, just on this slide, apologies, they are actually both at 7 p.m. So ignore the 6:30 on the right-hand side, it's actually supposed to be 7. But I encourage all of you to register now so you won't miss one in the near future. Thanks again, Dr. Kindred, for your wonderful lecture this evening and for teaching us all about hair loss, especially in patients of color. And thank you to our audience for joining us tonight for this wonderful talk. We hope that you'll join us next month.